Good morning, good afternoon and good evening, wherever you are in the world. I'd like to thank the conference organisers for the invitation to present this work. Before starting, I'd also like to acknowledge the traditional owners of the land on which I am doing this presentation. I'm on the land of the Guttermud people, the back of the Otway Ranges in Victoria. I'd like to pay my respect to elders past and present. This evening I'm presenting on hepatitis C elimination by 2030. I'd like to acknowledge all of the people that contributed to this important work. And as well, I'd like to make my declaration of interest. I received investigator-initiated funding from Gilead Sciences, AbbVie and BMS for projects that I work on. So hepatitis C, why should we care about hepatitis C? Well, because it impacts on many people globally, with an estimated 58 million people infected and 1.5 million cases annually, with up to 400,000 deaths occurring due to hepatitis C. And hepatitis or viral hepatitis related deaths, unlike TB, HIV and malaria, have been increasing over recent years rather than decreasing, so there's not control. Importantly, as well as causing morbidity and death, hepatitis C has a broader impact. It reduces health and well-being and the quality of life of the individuals infected with hepatitis C due to liver cirrhosis, liver cancer, and comorbidities. But importantly, there are other impacts of hepatitis C. This includes internalized and enacted stigma and discrimination. And this can have significant broader impacts with reduced social and workforce participation, reduced workforce productivity, and really marked personal financial security or insecurity, as the case may be, because of how hepatitis C impacts on somebody's ability to undertake work. Simple things like if a person is infected with hepatitis C, people say, oh, well, they're no longer working, they're older. But if that person provides childcare to the family, that also has broader impact. So it has multiple impacts. In the post-2015 development agenda of the Sustainable Development Goals, goal number 3 highlighted the need to combat viral hepatitis. It would have been nice if they'd said and joined the end the epidemics similar to AIDS, tuberculosis, malaria, but at least it highlighted the importance of combating hepatitis. As well, the Sustainable Development Goals talked about the need to achieve universal health coverage, including the financial risk protections, access to essential health care, and access to safe, effective and quality and affordable essential medicines and vaccines. And this is critically important when one thinks about efforts to eliminate hepatitis C. In acknowledgement that hepatitis C is indeed possible to eliminate, WHO in 2016 have set targets for reducing new infections and stopping deaths of an 80% reduction in new infections from the 2015 levels and a 65% reduction in deaths. Really challenging targets, but also I think it's critically important to understand if there's buy-in, and we'll talk about that more in a moment, that this is possible. They also set some specific targets around prevention with a focus on the need to increase harm reduction and the provision of clean needles and syringes. Also, it was really the need to be able to identify and diagnose people with hepatitis C was identified as being critically important. There were the impact targets, as I said, of the reduction in infections. And more recently, these targets have been updated. And important, I think, to note for hepatitis C is there's some absolute prevalence, incidence and mortality targets now as well. And that's really important for some countries that might have difficulty measuring what was going on in 2015 to now, but also in some countries where they've done a remarkably good job prior to, in some respects, the original targets, so that they have incredibly low annual incidence of hepatitis C, particularly in some high-income countries in terms of low incidence of people who inject drugs in those countries. So the targets have been reset. Why is hepatitis C elimination achievable? I don't think we should ever forget, even though we're kind of very used to it these days, the game-changing situation of curative treatments of the direct-acting antivirals. We have to constantly remind ourselves that this was an extraordinary medical breakthrough, a generational medical breakthrough that's enabled us to have people accessing once daily medications with minimal side effects and cure of over 90%. It's possible, but despite the setting of targets and the game-changing treatments, and as well excellent tests being available for hepatitis C that should make it possible to achieve elimination globally, we are not tracking well, with really only a handful of countries thought to be on track. And I'll acknowledge that this changes a bit, may change a bit with the new WHO targets, but the reality is there is not a storming of the barricades going on in terms of hepatitis C and countries achieving the elimination or the interim elimination targets. It's a massive challenge, and the reason for why we are failing is the massive lack of funding for viral hepatitis and the hepatitis C response. Despite the high numbers of infections and the rising number of deaths, despite the WHO targets, and despite having a disease that is curable, in essence curable, hepatitis C does not receive funding from global initiatives such as the Global Fund, Gates, the World Bank, Global Financing Facility, and this is very unlikely to change soon. And the reason is they talk about the impact of hepatitis C is not as great on countries in terms of their financial stability, them developing this, reaching sustainable development goals more broadly and the like. But I want to highlight the reason why I think that's a problem. I also want to note there are some admirable exceptions with UnitAid and also some leftover Global Fund money, which is through HIV, which might be, and TB, which might be a way of getting some of this global money. But why have we got to this situation where, despite the fact that we have a disease that we could eliminate as a public health threat, we're not making strides forward? And in my view, it's because we're in a non-virtuous cycle. Global health funding priorities have been developed over the years by a number of reports and programs, and they're very development focused and like, but a key driver is whether the disease in question is having a significant economic and development impact on the country and its individuals. So these are how things get chosen. Critical words and phrases to keep in mind are the Sustainable Development Goals, which I've mentioned, universal health coverage, which I've mentioned, but also at an individual country level, disease control priorities and country-specific health packages. And it is these things that are really important if we're to understand how to engage with countries to try and strive for elimination. So the Sustainable Development Goals and hepatitis C funding. As part of the Sustainable Development Goals, United Nations member states agreed to work towards these SDGs and universal health coverage by 2030, ensuring healthy lives and promoting well-being for all ages. And UHC aims to provide healthcare and financial protection to everybody, and it does this through looking at a particular country or region by providing a specific package of benefits, the country-specific health benefit package. And you might get a cheap loan from the World Bank, or Gates might lend funds or provide funds or the like. And the end goal of providing financial risk protection, improved access to health services and improved health outcomes to all. And diseases that are included in the country-specific health benefit package through their inclusion in the country's disease control priorities, as well as other priorities more generally. So to get a gig to be funded, as in to have funding put towards you to be eliminated, such as hepatitis C, you need to become a disease control priority. So particularly in countries where hepatitis C has a considerable impact, you need to show the extent of that impact so it's recognised as a priority disease. And so I'm about to discuss what I think the problem is. So here's the rub. To be included in a country's specific health benefit package, you need to show that the disease is having a significant impact in the country. How do you do this? You need data, disease prevalence, incidence, mortality, morbidity, and broader impact. But how do you get that data? Well, you need funding to get that data. You need to have surveillance systems or the like. And you need to model the data to show the impact that it's having more broadly. And you need funding to do any modelling. And treatment and testing costs are falling, so you need to show cost effectiveness. Data and modelling is needed to show this. And funny thing again, funding is needed. You need community awareness and agitation to raise the profile, to engage with politicians and bureaucrats about the impact of hepatitis C on the community, to fund the surveillance, the modelling and the cost effectiveness. But funny thing, you need funding to support communities to raise awareness. So as you can see, I could go on with this cycle for quite a while. But the reality is, how will you really know the impact of a disease on a country if you're not doing the work to properly measure it? And that's what's happening in many countries with hepatitis C. We need to raise awareness. There is an absolute lack of community awareness of the barriers to achieving elimination. Most don't even know that a remarkable cure exists. And the initial high pricing and press that came with that, for those that do know they exist, they think that they're wickedly expensive. But in fact, direct-acting antiviral therapy is now available at prices of less than $50 a cure. So if you think about that, that is extraordinary. So what to do about the slow progress despite having the tools to achieve elimination? We need commitment, leadership and investment. Work we've done through the world, through the Wish Foundation with viral hepatitis has looked at what is the kind of financial structures or the investment case that could be put forward. As well, others, WHO, working with Homi Razavi and others, have also done some excellent modelling in this area. And essentially what this framework shows in terms of where financing should come from, the activities required and the return on investment was clear in our work that hepatitis C elimination saved countries money. It was highly cost effective. We also in that report highlighted countries that were being successful. And I sort of thought about why are they being successful? And I'm just going to run through a few examples. What were the national activities in the country examples that was leading to success that others could look at? This included Georgia, where Georgia has made enormous strides towards hepatitis C elimination. And partly the reason they're doing that is because they had real political buy-in and developed a national plan that has been supported by the government. And then other funding has come their way with innovative programs of one-stop shop, working with the TB under one umbrella, all of those things. Some really great work is done. South Africa clearly developed an investment case. There's still a lot of work that needs to be done in South Africa. I'm not pretending that they've got this under control, but at least they've taken those steps of a national action plan with a clear investment case as to why it's a benefit to eliminating hepatitis C. In Scotland, they have again done some really great work in terms of elimination. John Dillon, Sharon Hutchinson and others. And critically is that they have had real pressure being applied and scientific evidence to raise awareness of hepatitis C and developed some political consensus to support significant funding and evidence-based policy initiatives and innovative strategies around surveillance data and the like. So they have basically used quality data and information to inform the government of the need for a response. Egypt has just done amazing things. It's gone from a country which had the highest prevalence of hepatitis C to treating a huge number of Egyptians in a short period of time. At one stage, they were rolling out testing so quickly that it was changing by the tens of millions of people being tested every month. It was impossible to keep up at one stage. And it's just been an extraordinary program of testing linkage to care and treatment, but also of massive political commitment and buy-in, where they've negotiated for cheap prices in drugs and cheap prices in diagnostics, and also a clear recognition of community-based care. Australia has taken a multi-pronged approach to elimination with a long history of partnership involving the community sector, who are strong advocates that then help fight for things like universal coverage for drugs. So for a high-income country, Australia has an unusual risk-sharing agreement with originator pharmaceutical companies, which enabled Australia to have universal coverage where treatment was made available to everybody, despite disease stage, despite whether or not a person had a history of injecting drug use, and also that it was moved into the community sector so that primary care doctors can prescribe hepatitis C treatment, and treatment was also made available in prison. And so it's really had a massive impact, and we're about halfway through our elimination efforts. So one of the critical things, as I said, is to have a clear investment framework of what needs to be done for viral hepatitis elimination. You also need to think about this return on investment. And the work that we did showed that between 2018 and 2030, the total cost of elimination is estimated to be 51 billion, which sounds a lot with minimal ongoing costs beyond 2030 though. But this, although that sounds a lot, this compares very well to the costs associated with the expenditure on tuberculosis, HIV and malaria. And critically important is that the direct benefits that you prevent these cases, but the indirect economic benefits are also there, and you begin to really save money through hepatitis C elimination. And when you look at individual countries, I should also mention when we've done this and applied this to individual countries, done it recently in Pakistan, this was clearly shown to be the case, that it's not only cost effective, but it becomes cost saving when one takes into account the important indirect costs of people returning to work, reducing absenteeism, improving presenteeism and the like. So how to finance viral hepatitis? Domestic funding is required to strengthen health systems and finance hepatitis C specific activities. And those health system costs are not just so, you need to think not just for hepatitis C, but improving health systems improves injection and blood safety. We've seen this in Georgia, where the health system and blood safety has improved remarkably. Harm reduction programs are not just for hepatitis C, but for HIV, hepatitis B and elsewhere. Strengthening surveillance system. In these COVID times, we clearly know that strengthening a surveillance system has a benefit for a particular disease, but beyond that. And in fact, it's vitally important that we bounce off what is being done with surveillance system and building capacity and surveillance from COVID into hepatitis C and other diseases. And technology to link patients to care. Again, we've seen with COVID things that were not thought to be impossible, ways to do this, telehealth and the like. And they're not just for hepatitis C, they can be for any disease. There's also hepatitis C specific costs, such as the cost of treatment. It's vitally important that we get quality negotiations go on in countries to get cheaper treatments and cheaper diagnostics. We need to think about innovative financing, blended financing, pooled financing, and various other mechanisms to try and do this. So the overall investment, the overall cost can go down and the return on investment goes up. So this is about improving affordability of hepatitis C elimination. We need to reduce costs by simplifying testing and simplifying care. There is no need for multiple visits to a tertiary hospital to eliminate hepatitis C. Work we've done recently in Myanmar and similar work done by others through FIND clearly show that you can have community-based treatment where somebody comes in with an antibody test, reflex onto a point-of-care antibody test where they reflex onto an RNA test, and either that day or the next day with that result can start treatment. So 2 visits to start treatment and maybe 1 visit to follow up. So we need to simplify testing and simplify care. We need to simplify guidelines, particularly in low and middle income countries. We need to get rid of lots of extra stuff and just really work on this, get people onto treatment. We need to move care into the communities with hub and spoke approaches to link people with significant liver disease to specialists. The reality is in many low and middle income countries, there are not that many specialists, hepatologists or infectious diseases specialists. So they should only see people who are really sick. And the vast majority of care can be successfully conducted by primary healthcare clinicians. Also, we can train nurses to take over much of the care. In Australia, a significant amount of hepatitis C care is undertaken by trained nurses. Nurses who have specific education and training for hepatitis C. We need to maximise the effectiveness of the local spend, sharing costs with other strategies, piggybacking onto existing infrastructure, looking at innovations and efficiencies over time, as well as looking for international donor investment wherever we can possibly get it. So where are we up to and where are we trying to go? It varies between countries as to where you are up to in your elimination efforts. But there are these common themes of simplify, move it to the community, reduce costs. But for the vast majority of countries, it is highly cost effective. So it's really engaging with community, making community the centre of this to get more people onto care. There are different phases of elimination, is how I like to think of it. You've got people who are willing, waiting and warehoused, and they're ready to go. You've got people who are motivated, but sort of somewhat not quite there, but quite easy to get into treatment. You've got hesitant and need social encouragement, and then you've got this small group who are doubtful, uncertain and unaware. But the vast majority of countries are still in this willing, waiting, warehoused motivated or hesitant and needing social encouragement costs. So we can do a lot with low-hanging fruit or fruit that's slightly higher to reach or on a different tree that's not right. So we need to address other critical barriers as well and simplify testing, care and treatment. We shouldn't forget the enormous stigma attached to hepatitis C and the discrimination. And this means that some people do not seek care. We know that in crossing borders, people still are required to have hepatitis C tests, which might mean that they're out of work and all of those kind of things. This needs to be addressed to engage people in care. We need to raise awareness. There's an absolute lack of awareness and lack of demand. And our healthcare services have to remove all barriers, including the stigma and discrimination that sits within many healthcare things, but also how we actually do clinics. A really simple example that I use is I do a clinic on a Friday morning. If I want to see people who inject drugs and they need to pick up methadone and they have to wait for the pharmacy to open at 9 o'clock, it's foolish of me to book them into my clinic at 9 o'clock. I need to see my people who inject drugs at my service at, say, after 10:30 or 11 o'clock, because it's too hard. We need to think about these really simple barriers that we put up. We need to think about retention and care over a lifespan. Probably not so important for hepatitis C, except in those people diagnosed with cirrhosis who will need ongoing follow-up. Other important barriers we have to recognise is within ourselves. Healthcare workers lack awareness about hepatitis C. The guidelines are complex. We need to simplify them. They lack support to manage hepatitis C. Often in a primary care setting, people say, oh, it's too hard, when it is simply not too hard, you just need some support. Busy, competing priorities, service delivery barriers, and chronic disease management is always a little bit, people living in primary care. So in summary, in my view, hepatitis C is absolutely technically possible, but we need countries and global funders to invest. We need countries to have strategic plans. We need to recognise how the Sustainable Development Goals, universal health coverage, and disease control priorities work. We can't be naive to the game. We need to make sure hepatitis C, if a country is revisiting its disease control priorities and its country benefits packages, we need to be helping, we all need to help those countries in terms of getting data together so that they put in a good bid for hepatitis C, or if it happens to be hepatitis B care, so that they really get those diseases prioritised where they should be. We need data to show the considerable impact of these diseases on the communities so they are made priorities. Where possible, integrate the response within the country UHC to save dollars and get included. This is really important. We need to make sure that we don't silo hepatitis C care. There's no need to. So we need to get within those funding mechanisms. We need to make it an exemplar disease. We may need to make it clear to politicians and policymakers that they will actually make great progress in a few years. We know politicians like short time cycles, policymakers like short time cycles. Hepatitis C is one of those ones where you, if you invest, can make huge strides in terms of your elimination within 3 to 5 years. At the same time, as all of these rationales for why we should do this, we should never forget that we are talking about individuals who are infected with hepatitis C and their families and friends. It is vitally important we keep people at the centre of this story. How does hepatitis impact on them, their family, their lives, their communities? The health system needs to work for these people, not them have to run around working for us. Stigma and discrimination are critical. The war on drugs has done untold harm and put hepatitis C, in my view, on the back foot. We need to change that. I'd like to again acknowledge all the people that supported this work and let us strive towards hepatitis C elimination. Thank you again for the opportunity to present this work, and I look forward to the Q&A. Thank you.
Thank you very much, Professor Hellard. If I may invite now Prof. Hellard to come online. Thank you very much. So just a quick thanks for such an insightful talk. I think it's certainly a very inspiring condition to be able to see of a cure. And of course, we are moving forward in big strides when it comes to Hep C elimination. What I would like to ask is what do you foresee is the impact of COVID-19 on these efforts? Do you foresee that in places where they are doing well, they'll continue to do well, or do you foresee a much wider gap in those countries that had essentially had at different paces of the elimination process? Thank you.
Yeah, it's a super good question, and I think the reality is we don't know the answer just yet to it. We know short-term COVID has impact where we've been able to measure it on people being tested and treated. We see that in a few countries so far where that data is available. So that's not a good thing. But there's also opportunities that are going to arise from COVID, and perhaps that if we can work out how to utilise the opportunities that arrive, then we will end up doing better than perhaps we were, particularly in countries where surveillance systems have been really limited to identify people with diseases. Perhaps the improvement and strengthening of health systems and surveillance systems will help us to then apply that to other diseases such as hepatitis C, or also hepatitis B, which is obviously a huge issue in many parts of the world. As well, COVID has shown us that community-based care can be really effective, and also I strongly believe that if we can again, strengthen community care. Most of hepatitis C treatment can be done in the community. It doesn't need to be done in hospitals. So I think that's, again, COVID might help us with that. And as by way of example as well, things like telehealth. For the last, in my city in Melbourne, we've had a number of lockdowns where we have not been able to see patients face to face, but we've been able to provide testing and care via telehealth, and that's done very well. So for a number of patients, particularly those who might be have difficulty getting to clinics, it also might be COVID might show us a different way to do things. So as much as I think it's causing us great challenges and it's going to be financial challenges, I think it also shows us there are other ways to do health and manage patients that might help us improve as well as that health system strengthening.
Thank you very much, Professor Hellard, for the very insightful answer. I think I strongly agree, and I think it's certainly points in COVID-19 that can certainly teach us the way forward. So thank you very much.